a particular person. So on that note, I want to welcome you all very much. We have, so far we have, I just want to give you a little statistics. Okay, great. So already we have 97 participants, and that is very interesting. So good day to you all, and welcome to this webinar. We just commemorated the World Suicide Prevention Day on 10th September 2020 with the theme Working Together to Prevent Suicide. And that has been the third year that we've been running this same topic, this same theme. It shows the importance we assign to working together, because suicide is not an individual person's problem. It's not for a particular sector. It's multifaceted, multi-sectorial. It's everybody's business. So we all need to be working together to prevent suicide. Our sub-theme in Ghana is working towards decriminalization of suicide behavior. Suicide is largely preventable, as you're all aware, yet worldwide, some of the leading causes of death, especially among the youth. Ghana is no exception. We'll be getting some data as we move on. And the current pandemic of COVID-19 disease makes the situation even more precarious. At this webinar, we have assembled experts, including a member of the legislature of the Ghanaian Parliament, to help us explore where we are with the decriminalization agenda and how well we can work together to bring the effort to fruition. We have Professor Joseph Osafo, a clinical psychologist and a suicidologist, and head of Department of Psychology at the University of Ghana. We also have Dr. Collins Badu Ajuman, who is the president of the Ghana Psychology Association. He is an industrial and organizational psychologist and a lecturer at the University of Ghana. We have Dr. Jimama Kankam, who is a board-certified psychiatrist and a distinguished life fellow of the American Psychiatric Association, a medical director of outpatient services, MedStar Harbor Hospital, Maryland, in the US. So she's practicing in the US. She's a Ghanaian American, and having been born and bred in Ghana, schooled all along up to the undergraduate level in Ghana, graduated at University of Ghana Medical School. She's very much in tune of what is happening here, and she also is very much aware of what is happening on the other side of the globe. So she'll bring to bear the experiences, and we're happy to have her here. We also have Ms. Favor Hilda Apini Brown, who is a counseling psychologist, and in her other life, she's a chemical engineer and a suicide prevention advocate, herself a survivor. Very important here. We have Honorable Kwame Enyimadu Entry, a member of parliament for Asante Achim Central in the Ashanti region. We are happy to have you, Honorable, bringing your experience from the legislature.
Thank you.
We also have Dr. Eugene Dodoi, a consultant psychiatrist, senior lecturer and head of Department of Psychological Medicine and Mental Health, School of Medicine, University of Health and Allied Sciences. Welcome to you all. I'm very happy to have you all here. You're going to be the moderator for this program, and I'm a consultant psychiatrist, a chief executive of the Mental Health Authority, and part-time associate professor at the University of Science and Technology. So on that note, once again, I welcome you all, and let's get started. So let me take Dr. Jimama Kankam to give us the first submission. So, Doc, can you review the world situation of suicide behavior, and tell us what is it like in the US? So as we come down to Ghana, you'll be able to see and compare and contrast. So, Doc, please.
Okay, thank you for having me, and thank you all for coming. And thanks to technology for putting me together with you all. Suicide, you know, the word suicide strikes a lot of, it's a tragedy anytime, never to be glorified. Okay. But we're here because it has an intersection with illness. Whole world, the body that we all look up to for the assessment and surveillance of illnesses and its burden on society is the World Health Organization. And it says suicide, the number one cause of suicide is mental illnesses, especially a group of illnesses that includes what is generally known as depression. And why is that so? Because it takes away hope, that window of hope. And that phenomenon of suicide is all over, crossing socioeconomic status, religion, ages, you know, and it's always been there. And according to WHO, about 1 million people lose their lives. Every 40 seconds, somebody's losing their life, okay? And these illnesses can be treated as Prof said. Unfortunately, there are barriers, okay, to treatment. Those barriers include access, but also awareness. You know, many people who have depression they go through phases, and one of these, in the acute phase, it's almost like taking away your hope. And although it is difficult for people to understand, the best way to see it as like being in a burning house, and we've seen people jump. So in this, it's not the people who get to these stages are choosing. They are unable to see hope. We take it for granted when we are in our good health. But in these states, individuals in these states are unable to see hope. And it comes in waves. And in one such wave, one makes an attempt. We also know that the highest risk of the next attempt is a previous attempt. And so the best is to minimize the phases, the episodes, as we call them. Okay. Suicide is all over. It is the #2 cause of death in ages 15 to 25. Think about it. That is true, what you said, in the past, secondary school all the way through college. So it's our children, our future. The sad thing about it, in the US, it's the same. With availability of guns, we see a higher percentage. For me, as a practicing psychiatrist in the last 30 years, it's not about statistics. It's about sitting across from hundreds and thousands of people who have been there. And if they had help during that phase, they wouldn't be. It's not only it is elderly. Actually, in the US, the highest is the elderly, white, widowed male associated with isolation. And as women attempt more, but men complete. We're getting away from saying that they commit suicide because it's not a crime, at least in many parts of the world. So it is the illnesses that cause it can be managed just like your hypertension or your diabetes. Okay. And we are gathered here to say in Ghana and a few other countries, an additional unique barrier is a law that says it's a crime to make an attempt. And how does it impact? While these illnesses, like other chronic illnesses that we all know about, like high blood pressure and other illnesses, the earlier you identify, earlier you treat, the better you have success. With the threat of being put in jail, then people are afraid to come out, and we'll hear about Favor's story. So the US, in terms of awareness, is not much different from Ghana and other developing countries. What we don't have is the fear of going to jail. And so that's why we're here today. And I hope that by the time we're done, we can convince everyone everyone that suicide, a tragedy, is part of an illness, and people need treatment and not, to be criminalized.
Great, thank you very much. That's very elaborate. So it gives us the picture of suicide worldwide, and so then you'll be able to come to Ghana and see what it is like. Now, Professor Joseph Ostafo, you are an acclaimed suicidologist. That means you've taken upon yourself suicide as your specialty, and we are therefore happy to have you here. We know you've done a lot of studies in your department. You've done a lot of studies on suicide in Ghana. So what is the current situation of suicidal behavior in Ghana based on these studies, as I mentioned, and other studies that you might be aware of? And so what is the nature of the data we have in Ghana?
Thank you very much. Thank you very much. And so when you take a look at the situation in Ghana, a lot of what we find...
I think it could be louder, please.
Is it better?
Yeah, it's better. Great, thank you.
Okay. So when you take a look at the data we have in Ghana, there are a lot of continuities between what we find elsewhere in the world and what we find here. But there are equally very striking differences. So for example, yes, we also see the same men will complete, women will attempt. In fact, in one of the data, the ratio was about 7:1. If you're looking at men and women in the differentials. So what we did since 2008 was to first contextualize this particular problem, which is suicidality. And the reason why we did that was to find out some of the cultural elements and factors that may, for example, feed into the expression of this behavior in our context. And so a great deal of attitudinal studies have been studied, right from health workers, psychologists, students, laypersons, religious leaders, which has just recently been submitted and accepted in the Journal of Pastoral Psychology. We've studied, for example, judges, we've examined the views of lawyers, and this was all in an attempt to provide a certain cultural metrics within which this behavior expresses itself. And also to determine what are some of the cultural factors that may, for example, become risk factors for persons who are going through crisis of any kind that may be suicidal. But beyond this level was to go ahead and estimate, for example, from the general population, what are the rates. And I think that recently when we came out with a press release in conjunction with the Ghana Psychology Association, we indicated, as you could see there, for example, right from junior secondary school to senior secondary school, 2 out of 10, 3 out of 10. In fact, we even left the universities, and that we have a data about 1,000 from one university that is showing that 23% of them have in the last 1 month, in the last 1 year, attempted suicide. So these figures really show that suicide is indeed becoming a public health issue that needs an urgent attention. If you look at, for example, what we will call the reasons, what sometimes are called in quantitative terms the risk factors, these have ranged from strugglings and difficulties with academic problems, academic underachievement, what we call romantic crisis, for example, in marriages, and those who are young people who are experimenting and trying to find their sexual self. Recently, we have done a study among the LGBT community, and that is very serious in there because of the social taunting that they experience. We also, for example, have examined what is happening around the countryside, especially in rural areas. In one of our studies in a rural community, it's so high that if you are tempted and survive, the reactions from your friends and families were enough to push you overboard to end your life. And so it doesn't look very well around the countryside as well. We've also had data among the elderly, and we are extending that one. For example, elderly abuse. Recently, we just saw this whole idea of witch hunting and how people are abused. We have just secured another funding to extend the study to universities, because it appears that what is happening in our universities can be an epidemic of a higher proportion that we haven't taken a look at. So that is just beginning, where we are going to sample about 10,000 university students across the country and see what is happening. But we have also been very much interested using phenomenological psychiatric approach to look at those who have attempted and survived and what are their stories. And I think that's an incredible opportunity to listen to those who have survived. What did they say was the reason why they attempted suicide? What were the drivers of those behaviors? For those who are dead and gone, yes, we can reconstruct, but your guess is as good as mine. We may make a lot of mistakes in there. But when they are alive, it's very easy to really hear them and let them talk and let them tell you what where this actually started from and where it got them to. And then you can, of course, estimate the risk as they leave and how best you can help them. And so we have had over 150 of such cases of those who are living. We just are analyzing another 25 sample now of those who have attempted and survived. And the narratives, as I said, when you look at our narratives, the general perspective that was presented by WHO in 2014 appears to be shifting. In fact, Lancet has just commissioned a group to look at suicide in low and middle income countries, and I am privileged to be a member of it. And this is the idea that is coming up, that the WHO's view that said in 2014 that about 90+% are coming from those who are mentally ill, seems to be changing in low and middle income countries. And that what is happening is that we are having so many social adversarial factors. We're talking about poverty, we're talking about abuse in homes, we're talking about violence in homes towards children, for example. We're talking about the way our educational systems are structured that make children struggle to even pass and get into the next level of their education. And so in just last year, a systematic review, an extensive systematic review, warned low and middle income countries to pay attention to social factors that are driving people very, very much towards this behavior. And so, and we're seeing a lot of these things happening in this part of the world. And so when interventions that are socially tailored are carefully done, they appear to be ameliorating and modifying this distress that people go through, and they are quite healthy. So to sum up, I will say that in Ghana, this is taking another turn. I must finally say that attitude towards suicide in Ghana appears to be in transition. The very negative, strong antiquarian views, which saw the suicidal person as somebody who must be criminalized, beaten up, molested, insulted, appears to be changing gradually. The change is that slow, but since the time all of us began working on this, and every one of those who have attempted, for example, began talking about this, it appears that we are beginning to see some glimmers of empathic responses towards persons who are living or who are going through such crises. So thank you very much.
Thank you very much. That's also another elaborate submission. So with that, you've got a clearer picture of the data as you have in Ghana. You realize from what you said that it's not only a particular segment of the society that we are all at risk. Okay, so with that, now let's move to Dr. Eugene Dodoi. You are a consultant psychiatrist with a lot of experience, and you are currently a senior lecturer at the University of Ghana. So with what we have so far, what would you say are the common causes in our circumstance and the determinants of suicidal behavior? And why should we consider suicidal behavior as a health issue, maybe rather than as a criminal or spiritual or some other issue? So, Dr. Dodo.
Thank you very much, Professor, and thank you for the opportunity. I'm trying to share my screen, but I'm not being allowed to. So, just screen, yeah. So, I'll be telling us why this is a health issue. And for me, this has been what we've been battling out for the past 12 years when we started this campaign of decriminalization. So I'll talk about the causes of suicide, the risk factors, and what I term the ABCD of suicide. Just the ABCD, the suicide equation and the management of suicide, so that we can be able to understand what this whole suicide is about. I think I can share my screen now. Yeah, so the cause of suicide, and I mean cause. And this is important for listeners that because when we say something is a cause, you usually have a challenge. I mean, it means there is something that can relate from A to get you to B to D or to C. So we think suicide, the causes of suicide is not fully understood. It's a complex of events that culminate into suicidal behavior. And we have a couple of stuff that we think that are associated. And this is what we refer to as the risk factors. So for the risk factors, I put them into ABCD, just for us to easily know them. I think there's a challenge. I can't move my slide. Yeah. So when we talk about the ABCD, we are talking about the A is for the affects, B is for the behavior, C is, for the cognition that goes on in people's mind when they want to attempt suicide, and then D for drugs that probably we prescribe and make them suicidal. That's interesting. And the E for the environment or other events that happen that will culminate in suicide. I'm still not able to move the slides. I'm not too sure why. So when we talk about the affects, so the affects is, A affects basically means emotions, your feelings. So what are some of these feelings that make people unable to really realize that, they have a problem and need help? So one of them is when people are fearless and they have pain insensitivity. This trait has been shown to be the reason why men tend to complete suicide more often than the women, because generally we think that the men are able to kind of endure pain. Some too think it's probably not a cause effect, and that's because when you go through labor, there's more pain than that. But this fearlessness and pain insensitivity has been highly associated, with the suicidal thoughts, and probably, with the male androgens, and that is what makes men more likely to complete suicide than women. Then there's this feeling of belongingness, so that when people do not feel they belong and they are somehow socially isolated, it makes it difficult for them to, I don't know what to do to.
So you just, what you can also do is that you can send us your slides and we'll share from here, and I can control from here.
Okay, great. So, okay, I'm not too sure. It appears okay. I can move it now.
Okay, great, wonderful. Then go ahead.
Is it still showing?
Yeah, it's showing. Great.
Okay. Yeah. So we have over 95% of people who die usually may have a medical condition, and over 90% of these people, I mean, tend to have one form of psychiatric disorder or the other. So this is not to say that people who have psychiatric disorders are always suicidal. In fact, most people with psychiatric disorders are not suicidal. So if most of them are not suicidal, yet majority, over 90% of them who actually died by suicide had a mental disorder. That tells you that if we look at mental health, we are looking at over 90% of preventable suicide deaths. So as I mentioned about the ABCD, so the affect, the behavior, the cognition, the drug use, and the environmental factors. No, stop moving again. Yeah.
Okay, I think I just run us through. Sure, yourself. Go ahead.
Okay. So the behaviors which we normally have associated with suicidal behavior, or what we call suicidal behaviors. It's been observed that over 79% of people usually, will become agitated or aggressive before they die by suicide. So agitation and aggression, either towards other people or towards animals, has been largely observed as a way to have when people also have what we call neuroticism, people who are too much concerned about criticisms, about their life and all that, these people are more likely to also want to more or less die by suicide or have suicidal ideation. One intriguing fact is people who are perfectionists. Perfectionism itself may not be a bad thing, it's helped you to achieve a lot. But when people believe that there are, family members and loved ones have the higher appreciation of what they can do, or people expect so much from them, when they are not achieving them, they feel that they have disappointed them. And that explains largely to the high suicide rates we have in Japan, like for instance. So some behaviors have been shown to really, put people in, so the C is the cognition. So for cognition, there are, and this is probably the chunk of it, what goes on in the people's mind, why they feel, hopelessness has been ascribed as one of the major reasons why people are suicidal. But it's been shown that hopelessness alone, even though make people get suicidal thoughts, is not enough to make them want to complete suicide. So there are other cognitive or thinking disorders or abnormalities that happen for people to go on to, have. One of them is having an absence of positive future thinking. Again, the reverse is not true. So it's not like if you have presence of negative future thinking, then you're also likely to come in. But the fact that people do not have a positive optimism about life, they do not have a positive outlook, so that lack of it is a problem. When people do not have enough reasons for living, and this is I mean, commonly among, what do you call it? When you look at the Protestants and Christians and even Muslims, some of them will tell you that because it's a sin, because they believe there's life after here. So they have a reason to live. So some of them will not will not die or complete because they feel they have a family. So they have a reason to be alive. And that is why they are around. When people feel that they feel defeated and entrapped, that there's no way, what Dr. Kankam once said, learn helplessness. They don't feel there's any way out. These people are likely to also, engage in suicidal behavior, not only their thoughts, but also go ahead and attempt. When people have poor problem-solving capacity, so they are not able to solve their interpersonal relationships. This is one factor which has been shown to also make people prone to. When we do not have coping mechanisms, so by coping mechanisms, meaning that all of us are going to go through stresses of life. If we are able to harness the resources we have to be able to go through our resource, to be able to overcome our stresses of life, then we better live. But when we are not able to harness these resources, these potential resources, then we feel helpless and we make suicide, an option. And that is more common with people who are impulsive. So impulsivity is when people do not think through their plan before they carry out. And that is largely what explains even personality disorder being, a challenge in suicidal behavior. Because one, they are impulsive and they are inflexible in their thoughts. So they think one way to just manage life is one option. I die, and that is it. So these are very important. The next one is about drugs. Interestingly enough, some of the medications like antidepressants, which are used to treat depression, the most common cause for suicidal behavior, has been also found to increase suicidal thoughts and suicidal behavior. So sometimes people become suicidal because of the drugs doctors have given to them. There's a class of drug, a class of antihypertensive. These are drugs being used to treat hypertension, which make people suicidal. So in fact, the prescribed medication we give to people can make them want to kill themselves. Then they look at the environmental factors. So the environmental factors are largely just three of them: social factors, negative life events, and interpersonal stresses. So if you look at the social factors, if they have a family history of a mental illness, of suicidal behavior, not necessarily a mental illness, they are more likely. When people are exposed to suicidal behavior, they are more likely to also want to, die by suicide. When the media glorifies suicidal behavior, there was a case in Ghana where Metro TV, I think a staff died by suicide, and the media made it that yes, it is because of the treatment of the organization to their staff, and that is what caused. So by that, you are glorifying and justifying suicidal behavior, and that will kind of give people the ego to also go on. And there's social isolation, which we'll come to later because of social distancing. What we are not too sure of is the effects of internet. Because some say it is a place where people air their grievances and therefore get sorted. Other people think that when people get in, there is cyberbullying, there is, people stalking them and stuff, and that's make them suicidal. When we have negative life events, like childhood adversities and traumatic life events in adulthood, interestingly, this has been shown to have a dose-response curve. And when I say dose-response, what we mean is that it appears the more severe the adversity, the more number of adversities is likely to make one more suicidal. That's what I mean by a dose. So when you increase the risk, you increase the likelihood. And that is very alarming, because among all the psychological trauma, rape has been found to be one of the most significant. It's both physical and psychological. So when children are exposed to, traumatic events, they are likely to also have suicidal behavior. And those with chronic medical conditions, as I mentioned earlier. Interpersonal stresses, when people have romantic relationship problems, a breakup, and all that, they can give them. When people are going through legal challenges, they may have a problem. When there's a sudden loss of income, or a sudden, drop of your livelihood, these are prone to make people want to die by suicide. And we've seen this especially in tomato farmers in India. And when people are in a non-heterosexual orientation, they have been found to be at a higher risk of suicidal behavior. When people generally are of low income, yes, bullying and victimization. So why do we think that all these factors which are related to their health, which most people may not have control over, why do we still think that these are criminal, they are bad people? Because if you will talk to people who have survived suicide, which I believe Faber will talk about, when we talk to them after, they no longer wish to die. They now realize that, in fact, what they had at that time was not right. They all admit later in life that they are grateful for not being allowed to die. So why should we kind of make a law that make it that if you don't die, we punish you. If you die, then good. So that does not help us. It's also been shown that people who have been exposed to treatment, when they become suicidal again, are more likely to seek help, because they realize that thinking is not normal. It is a disorder. Not they are bad people, not because they are criminals. And there has been, studies all over the world that have shown that when we adopt a public health approach to managing suicidal behavior, the rates of suicide decrease. So this has been shown to work, and no country has been able to reduce suicide rates by enforcing laws. So the laws have not been the way to go, and the science has shown us. So I think going forward, we should understand that what I call the suicide equation. In a predisposed person who has a mental illness, if they get access to a lethal means, then they will complete a suicide. So when we want to really prevent suicide, we can look at these areas, the A, B, C, D, E. Then we look at people who are predisposed to getting, the event, the suicidal behavior. We manage them, we screen them, manage those who are predisposed, treat mental illnesses, and restrict access to lethal means of death, which means guns, drugs, overpoisoning. Our oceans, our water bodies should be guarded. And with this, we are likely to decrease our suicide rates. And this is what has been shown to work, the public health approach, not the legal approach. Thank you very much.
Thank you very much, Dr. Dodoe. That is another elaborate presentation of determinants of suicidal behavior and the justification why it should not be considered a crime, but rather a health issue. On that note, then we move to Dr. Collins Badu Ajiman. You are the president of Ghana Psychology Association, an industrial and organizational psychologist yourself. So why should suicide behavior be decriminalized? And what have been the efforts? In fact, why it should be decriminalized? I think Dr. Dodoe has, and previous speakers have talked a lot. But what have been the efforts in Ghana, and what have been the challenges that we need to recognize, contend with, so that we can determine our way forward?
Right, thank you, Prof. And thank you, earlier speakers on this particular matter. And I think the good job done by my own Akonta and Dr. Eugene Dodoe has made mine slightly easier. If you look at the first part of my question, why should suicide behavior be decriminalized? And from what Professor Osafo said, from what Jemima also highlighted, and how Dr. Eugene Dodoye concluded, I wouldn't say it's becoming a public health issue. Suicidal behavior and suicide in itself, for me, is a public health issue in Ghana. And let me compare it to coronavirus. It's been how many months since Ghana Health Service took a decision to prioritize arrangements leading to the containment of the coronavirus? I remember when the discussion started with the director in charge of surveillance, Dr. Bedusa Kodie. It was around January 21st that Ghana Health Service started initiatives to handle coronavirus. And so if you take it from January and we are in September, how many months? We have less than 300 people dying from coronavirus from our records. And it's already a public health issue. And let's look at how much resources we have committed, how much work that has gone into containment of coronavirus. Less than 300 people, and it's already a public health issue. And from the records, the research statistics, if we have more than 1,500 people dying annually in Ghana, which one should be more of a public health issue? These are questions we need to ask. So I think it is a health issue, and we cannot imprison people for being unwell. And that is a point that we need to cement. And the reason why this is very important from all practitioners' perspective, thus far, we are taking records from practitioners. We will not only wait for a commissioning of a research before we support our drive. And that is where I like what Dr. Kankam said. Apart from the statistics, we, the practitioners, we sit with them. We welcome them day in, day out. Listening to their experiences alone is enough a research. What, as practitioners, we are thinking of is to able to add all these to the statistical research Professor Safo, myself, and others at the research institutions will be doing, so that we can have a triangulated data to be able to make our point out of this. So first of all, once suicide and suicide behavior is a health issue, we need to handle it as such. We cannot imprison people simply because they are unwell. Now, if you look at the other part of the question, what have been the efforts and challenges so far? The effort is that day in, day out, every year, we mount a campaign. And this year, that is what we are doing right now. Just on the 9th, we mounted a campaign that led to a press release in consultation with our partners, Mental Health Authority, Psychology Department, WINIBA, all the psychology campuses. We came out with a press release. We gave some statistics. We circulated ourselves to all the media houses to promote awareness. And this has been the effort to educate, promote awareness to Ghanaians. One thing that we have done as far as efforts are concerned, we are not only using English language. For we as practitioners, we want to use the language of the heart. You know, my father and Imadu, where he comes from, my father comes from the same area. When you speak Chi, Fante, Ewe, Dagbani, to explain what it is, it helps people to understand. Over the years, there may have been interventions, but trying to speak the language that someone truly understands to convey suicidal education has not been popular. And one of the things we did this year was to put in this effort and step up awareness. In addition to that, time and again, as researcher practitioners, we have been to Parliament, we have submitted documents upon documents to our parliamentarians, But coming to the challenges, what has happened? Thus far, what I will say is that Ghanaians are beginning to understand that suicide is a state of unwellness. Suicide attempts is something to do with someone's psychological health, precipitated by a number of risk factors. Ghanaians are beginning to understand. The media are buying into the understanding we are shaping with research and the practicing data that we have. Now, if you look at it from a researcher perspective, we understand it, and our message is the same. Psychiatrists, psychologists, practitioners, they understand it, and the message is the same. Now, let's come to an important group in Ghana. Policymakers, lawmakers, parliamentarians, position holders. And I'm very happy Honorable Animedu is here, and he himself will share his lived experiences. And I just want to cite one example why one of the challenges we have is not the general masses of Ghanaians. It is not about the media and media practitioners, but the few parliamentarians we have, not all parliamentarians, few so-called influencers of parliamentarians who are making our effort difficult. I have just few details to share. I remember November 1st, 2019. One of our honorable members, the MP for Jaboso, Kwabena Minta Akando, he laid on the floor of Parliament the position to decriminalize. This was supported by another MP, Honorable Joseph Yelechere. And I was excited for once. From both divides, a discussion started by someone, another supported. And here comes two influencers. And this is a public knowledge, so I can mention names. Joseph Osei-Wusu, who is a first deputy speaker, he mentioned categorically that there are some matters we should just allow to lie low. What did this mean? Trivializing the extent to which suicide can be a carnage in our society. He highlighted the fact that suicide is a trivial matter, more or less, and we need to look out for weightier matter. Then what came to my mind is that the key proverb, this is something we need to allow research-driven knowledge, evidence-based driven knowledge to help our parliamentarians to begin to see things differently. Sadly, it was supported by another influencer in Parliament, Haruna Idrusu. He also supported the motion, thinking about the so-called deterrent effect. And one question I want to ask, and I'm happy Honorable Kwame Animeduenchi will come after me. One thing I want to ask, the Health Committee of Parliament, the colleague parliamentarians, what was the basis for their thoughts that were expressed this way if he could get into the mind of Joe Wise and Honorable Haruna Idrusu, two influencers in Parliament who shaped discussions in Parliament and what led to that viewpoint? Now, aside this particular incident, I just want to go back, something that happened June 14th, the report that came about someone who nearly attempted suicide at the gallery, the lobby of Parliament. One of these same persons made an argument that they should step up security. How would you know the mental health status of all people who enter Parliament? How would you know? Do you take a Muslim man, a security officer with a gun to separate someone with a good mental health status from people who do not have the right frame of mind? Do you need a gun to do that separation? That is a question I ask. Most of these, our parliamentarians, were worried with that particular story, June 14, 2019. And if you look at what they did, talking about the challenges we have, the reports from the news media indicated that the Parliamentary Protection Unit, led by Superintendent Freeman Tete, They came for the person, took the person to the police station for investigation. If suicidal attempt is seen as a health issue, why would you, on a first count, take the person to the police station for investigation? Meanwhile, it is the same parliamentarians, some of them, who are also arguing that no judge has ever prosecuted any suicidal attempt. And that is also not true. Because I remember my good friend, Dr. Dodoe Makonta, mentioned not long ago, even on Joy, giving specific names about people who have been what? Prosecuted and jailed simply because they attempted. So in summary, the masses of Ghanaians, we researchers and practitioners, we are helping them to come to an accurate knowledge. They now understand suicide is a health situation, and to me, suicide is now a public health emergency. If you look at our press release, you could see younger ones, JSS, 3 out of 10 in the last 12 months contemplating suicide. You could see those in their adolescent ages, 2 out of 10. And now the most important thing which I need to stress, not to scare position holders, parliamentarians, and lawmakers who are not yielding to our call. Think about 3 out of 10 policemen in the past 12 months have contemplated suicide. Honorable Kwame Enyimadu, do you have a policeman who guards you? Do you know his mental health status? We have drones of policemen guarding the president of Ghana, the vice president, ministers, top position holders, heads of commissions, and what have you. Do we know their mental health status? It's a question I am asking. If 3 out of 10 policemen have contemplated suicide in the past 12 months, then I want to say categorically, if lawmakers do not yield to decriminalizing suicide, and for that matter, pass the various LI that is necessary to activate the practice of psychology and the practice of psychiatry in the best way, supporting with a budget the practice of what mental health standards in Ghana, no position holder, no parliamentarian, no topmost position holder who is guarded by a policeman is safe. Secondly, let's look at our transport industry. They always talk about transport. Our roads are not good. Vehicles are not good. I think differently. If you don't check the mental health state of all people we give license to drive on our road accidents will never stop in Ghana. Because for you to check your eyes, Y, Z, F, and then you give a license to a driver to drive on the road without understanding the mental health state, we are risking a lot of people, and this will not stop. So in conclusion, our challenges predominantly are not from the masses of Ghanaians. Our challenges in decriminalizing suicide is not largely from the media. The people we practitioners we have successfully treated, the people who have recovered, they are in support of us to help deal with suicide-related issues. It is rather few parliamentarians who do not understand evidence-based policy intervention. Our parliamentarians, few of them, who do not understand the need to rely on research in making decisions and probably look at things from a social commenting perspective, who are making our effort to decriminalize suicidal attempts difficult. Prof, your microphone is muted.
All right, thank you very much. And for letting me, and thank you very much, Dr. Badiajiman. You've shown why we certainly will need to decriminalize this. But before we hit hard on the parliamentarians, let's wait until we hear what Honorable Enyimadu will say. Because a lot of water, I know, I can tell you, a lot of water has run through since the last time that statement was made, that no way to decriminalization. And Favor is here. If I the honorable, well, I don't want to take the wind out of your sail, but let's wait until we hear from him before we take the parliamentarians to that. But before Honorable Animadu, let's take Favor, Ms. Favor Hilda Apini Brown. She is a survivor herself, a counseling psychologist, chemical engineer, and she will tell us quite a few. So Favor, as a survivor, lucky enough not to have been jailed. You were lucky enough not to have been jailed. What's your take on the persistence of criminalizing suicide in Ghana? So Favor, please. Favor, you are muted. Okay, let me unmute you. Unmute and then.
Hello. Yeah.
Yeah, that's right.
Good morning to all our listeners.
Good morning.
Who are on board. Yeah. It's sad and so disappointing for me being a survivor, and then having gone through. I've virtually gone through the phase of from beginning to end of what the law says in Ghana, that if you attempt suicide, you should go through. And it's been very hard for me to, even understand what went into fomenting the formation of that law, because I personally don't see why I need help, and then I have to rather be sent to jail because I need help. It's sad and disappointing. Being a citizen of a state where, you feel that at the point that the state should rather be coming to help you, coming to your aid, the state is rather saying that you have committed a crime, so you should go to jail just because you were at the lowest point of your life and you needed someone to come to your aid, someone to talk to, someone to just help you get out of that situation. Let me just narrate briefly what I went through before I go to talk about this persistent, nature of our law that is being forced on us. Because for me, it is forced on us because as a citizen, I don't think that we should allow it to continue, and we have to rise up and then fight against it. I had an experience where a relationship that I felt that, this was my whole life, was built around it, and my life was built around it. I felt I needed this relationship so badly. It broke down. So I felt, what's the use of staying in this life if I no longer have this relationship? So I attempted, taking my own life. Then I was at work, and then I got a call at the reception that there were 2 policemen looking for me. I came down, and then I was told that there was an arrest warrant for me at the Sherman police station because I had attempted suicide. I was like, seriously? Because at the time, I didn't know there was even a law like that. So they took me to the Ashaman police. Luckily for me, it was the commander who, came to my aid. After talking to me for some time, he was like, you don't even look like someone who wants to die. So I think it is because of what you were going through that led you into that. So I wouldn't process you to court. I will try to get the Dovsu woman to help you. So that was when I, got to know that there was even a law saying that if you attempt suicide, you should be sent to court and processed and, possibly jailed. And it was so disappointing. At a point, I even felt like, this country is not worth living, because at the point that I needed help, they rather opted, that the best the country could offer me is jail. It's sad. It is unacceptable. And I think that, the Mental Health Authority is doing its best. We as advocates are also, helping. But we need our leaders to take up this issue and, let's finish this thing once and for all. Let's decriminalize, attempted suicide. Because me, for instance, for the whole of my life, at the time I was 29 years, I never had, you know, any lessons on mental health. Unfortunately, I also didn't read about it myself. So the state already had failed me, because we should be able to inculcate mental health in our school system. So I should know that, you know, at this point I am breaking down and I should seek for help. And even where to seek the help should be made available. Then the state should be able to provide places where I can, you know, seek for help. And these places should be made known to each and every citizen, so that when you are, you know, going down, when you feel that, you know, I'm mentally not okay, or something is bothering me that I need to seek help, you would know where to go to. That has not been done. You see, so as a country, we have failed people who are mentally ill. Look at our mentally ill persons. They are all over the streets. Nowhere to lay their heads. They are under the mercy of the weather. You know, everything bad that is out there, they eat from our garbage dump. Who does that? We've not given them the help that they need. So you have not provided what you should provide as a father to your children. Then when the child is going out of the way because of the fact that you have not provided, then you again try to, you know, play the you know, master, and then arrest the person. It's wrong. So as a nation, we have failed mentally ill people. We have failed people who are suicidal, because we don't have the facilities. We don't have the places that they can go to. So we can't turn around again and then keep this law in our books that they should be, you know, jailed. It is not acceptable, and it is disappointing, having experienced it, working with people who are now experiencing it, because it has not stopped. It has not stopped. If someone tells you that, you know, people are not jailed, it's not true. Like I narrated my story, it was only the commander that, you know, made sure it didn't happen. And even he can't be taken on per the law, because he was supposed to do what the law says he should do. But he just looked at me and felt that, no, let me give this lady a chance to rather get help from the DOFSU, you know, coordinator at the time then. And she took me through counseling. She linked me up with a psychiatrist. Then I got in touch with Gifty Auntie. Through her, I was able to get Dr. Dodoy. And, you know, my life has not been the same, you know, since then, because I felt that, no, if I have gone through this and then this is what I've experienced, then someone who is not as enlightened as me, or who do not have the opportunity to meet people who are at the helm of affairs of mental health like I got, what would happen to the person? Because as we speak, the people who commit suicide that are not reported are far more than what we know. Because there are villages like where I come from, they don't want to report it because of the stigma. So if the person even gets to know that it is a criminal offense, then you are pushing the person to use a sure means of death. And that was what I was, you know, pushed to, because when the first attempt, I was called to the police station. Then subsequently, I felt that, okay, if it is a criminal, now I know that it is a criminal offense, then the next time I am trying, I have to make sure that I succeed. Because if I don't know which police station they will send me next. The person may not be, you know, as merciful as the other commander. This is not fair. This is not what a country should be doing to its citizens. No, it's unacceptable, and it's sad. It's very sad. I get very emotional because my life would have, you know, been just messed up because of a pain I was going through that I needed help. Then you take me to jail. Then, you know, what have you done to me? 5 years, I come out, and what becomes of me? An ex-convict? Because I had a situation that you should have helped me. If you can't help me, just leave me the way I am, and then, you know, nature or providence will find a way of helping me. But don't jail me. No.
Great. I think that's a very passionate expose of the real issues. And again, as I said, I'm sure that Honorable will have responses for us to calm our nerves down. Honorable, do we now return to you? Do we now come to you So what have generally been the attitude of your colleagues in Parliament towards this issue of decriminalization? And what would you say is the main challenge that we need to recognize? And if you have any knowledge of experience you want to share, maybe to add more weight, fine, please. So Honorable, let us hear from you so that everybody will know that Parliament is now, in terms of this issue, probably it's a different breed. Please, Honorable. I think you are still muted, Honorable. We are still muted.
Okay.
Yeah, great. Wonderful.
Right. And this is a very emotional topic to me. And I'm sure Dr. Kwesi Osei knows why he chose me, because I'm not the only parliamentarian. Unfortunately, on the 24th of February, 2017, I lost my daughter through suicide. Now, I am going to look at it from two perspectives. The first is to go look at the reasoning behind the lawmaker for criminalizing suicide. And then the second is whether this law must be sustained. Then I feel very humbled and well educated this morning. But the lady that just spoke, if she had been next to me, maybe I would have beaten her like my daughter once she got closer to me. Now I am understanding the lawmaker making it a criminal offense because she doesn't understand what she would have put her relations through if she has succeeded in doing that. This is very bad. Therefore, to me, I think the lawmaker is looking at it that if you have committed suicide, I have a friend that the son had attempted suicide more than 4 times. In some occasions, he falls down in a tub and whatnot. When this happened to our family, one of my children that comes immediately after my daughter, she was reading chemical engineering at KNUST, and she committed suicide by hanging. Up to now, I haven't found the reasoning why she did that. There are 2 theories to that. One is saying that she was referred in a paper. Another is saying that she had a boyfriend and the boyfriend jettisoned her, and that's why she committed suicide. Whatever, what we are going through as a family is too much. And I do not know whether she thought of the family before deciding on this. So that if you are incarcerated, maybe you will not have an opportunity to actually repeat that inhuman act. If my daughter had been arrested and jailed for some years, I would have been happy because she would still have been alive. So it's a very inhuman thing, but I think the lawmakers had a reason for doing that. I still agree with what the others are saying, that, well, if she had been around, if my daughter had been around, if she had been arrested, if she had been jailed, I would have done everything possible within my means to actually reach her, to actually come out of jail, to actually educate her, to actually counsel her and make sure that what she is going through is put to pass. But we must actually, we all have a responsibility to educate, especially at the universities. There are a lot of funny things that go on at the university. I was a lecturer before I became a parliamentarian, and there are a lot of from occultism and whatnot. And these children, when you put them at the schools, you do not know what is happening to them, and you do not know what they are going through. Now, I still don't want to talk about my daughter before I answer your question. This girl was very unassuming. She was a very happy child. and she was my friend. She confided in me, discussed everything, but I never had a clue. On that day, the 24th of February, I was supposed to visit her, but I fell sick. I was at the office when somebody called me, a friend called me that he wants to come to my office. And he came and said that this is the news. And initially he said that there was an attempt. I called at the school and she was gone. And I'm still, the pain is still there. I haven't gone through that. But Doc, with this background, you would understand that I will be the first to say that, look, somebody who attempts a suicide would need counseling. And therefore, putting the person at the prisons would worsen the situation. If, for instance, she's in jail and she gets something that she could use, whether it's a knife, whether it's a thread or whatever. If I tell you the circumstances upon which my daughter went, it was a small thread within the room, as if she did it herself, a small thin thread that she used in her room at the university. So maybe the parliamentarians that we're talking about also need to be educated. Of course, we are humans. Now, the interview that my brother said, when the message about Honorable Joe Oseusu, he happens to be my friend. I don't know. I was not privy to what he has said, but I think if it happened around February 2017, if it was close to that date, then I can understand him, because he's a very close friend of mine. He knows my daughter. He was very free with my daughter, and therefore maybe he was also going through emotional stress. Maybe he could be forgiven here, but I think we need to actually address the issue. Dr. Kwesi had actually brought mental issues to Parliament, and we have supported him. Once parliamentarians understand what we are dealing with, I do not think that we'll deal with it as a trivial issue. And ever since my daughter passed on, sometimes people call me to find out what my views are on this topic, and I'm always silent on this because I'm still going through emotional stress. What was worse was that the son, my son, that is her brother, that immediately comes after her because of what the daughter had done. He also couldn't stand it, and he told me that he wanted to end his life. Is that what anybody that attempts to do this would want to take a family through?
Sorry, Honorable.
Maybe.
We are really sorry. We are really sorry. And if you need to take a few minutes off to calm down, please do that. But we totally appreciate your situation. So you calm down and we'll come back to you. But in the meantime, what I have been reading the charts, and we are all, please, the panelists, you can read the charts. Some of the questions you can answer directly. After reading the charts, what I'm getting is that the Honorable Member of Parliament's earlier submission, I mean, the beginning of his submission, made people think that he's against decriminalization. No, he was just portraying what the lay public, and therefore the lay parliamentarian, sees it, and his reasoning, their reasoning behind that. So that is from the lay perspective. And once we understand that lay perspective, that, oh yes, if you do that, we are putting our the family members through hardship, and therefore let's jail you for attempting to do that. That is their lay perspective. Once we understand that, then we can address it. And now he comes home to say that, having been educated the way that we've all shared the experience this morning, he now fully understands the fact that it's a health issue, it's a cry for help, and therefore his attitude will be different. So that's how, please, participants, I want you to appreciate it. Not that he's supporting continuing criminalization. So, Honorable, if you've calmed down enough and you want to continue, please feel free. I think you are muted, please. Honorable, you are muted.
Right. The question, if you can hear me now.
Yes, I can hear you
I
now.
would want to sound a question. Those of you doing the research, it is a very important topic. But if I use my daughter as a test case, you cannot look at the face, look at the behavior, and predict that this person will do it, because she was so happy. She was not somebody you could hide. And according to the university authorities, 30 minutes before the suicide, she was all over her hall talking to people and laughing. But it happened. We have to help our children, especially the teenagers, because anything could happen. But maybe, pardon me, those who understand that I support that the criminalization should go on. No, that is not my view. I am actually saying that that is why maybe in the past, the lawmaker was reasoning to do it again. But I think that is wrong. It is about time that we have to give the trend. For instance, when my son told me that he felt like taking his own life because he was so much attached to the sister, what I had to do was refer him to a psychologist. I had seen 2 different psychologists already until the situation was controlled by the psychologists. So no, it is the punishment is the key to solving this problem. No, it is not. But I think that in Parliament, we need to be educated as well. And I can assure the members of the panel that I am not sure the view that the public is getting about Parliament on this topic is right. And as I said, I know Honorable Joe also very well. And I think that, well, if we trace at the time he said that, probably he was trying to protect me, that it was something I was going through, an emotional stress, and that I'm sure it was around the time that some colleagues had made a statement on the floor of the House. But I think if he said it, he would be forgiven. And I'm very sure that if this topic comes up for discussion, he would be somebody who will support it. And I foresee that he will probably be in the chair to actually drive this and amend this. And then this, I would want to say that it is not difficult going through this. Maybe the Law Reform Commission, those who would want to help, like Dr. Kwesi was saying, the panel members, will have to look at the Law Reform Commission. And once it gets to Parliament, I do not know the state. Some of us can assist to actually make sure that this is correct.
Thank you very much, Honorable. And once again, our deepest condolences over the loss. And we also wish to strengthen you and we collaborate with you. It's good that you're taking the step to get the second child through counseling, and you'll liaise with you and support you further.
Yeah,
so
he's all right.
You'll do that. But let me also say that indeed, at that time, the honorable minority leader also strongly objected to the idea of decriminalization. But since then, we have followed up to him, and when we explained the circumstances, what exactly we meant, he admitted that he did not understand. And he thought we were just saying, it is my life, leave me to do what I want. And if that also you are going to encourage people, he admitted that he had a change of mind following that encounter. And there are other MPs we met as we were coming, and he also agreed. So that's why I said that I'm sure that following that day, there has been quite a lot of water flowing under the bridge. So you get it. Now, on that note, let me acknowledge the presence. By the way, let me say that we initially wanted to have just 1 hour, but as you agree, it's been interesting and we have had to continue for some time. I hope that people have the opportunity to remain. But let me just go through a few people that we have here. We have Professor Latif Sheikh of Ahmadu Bello University in Zaria, Nigeria. We have Dr. Samuel Wahine, immediate past head of the Department of Psychiatry, University of Ghana Medical School. We have Professor Angelo Foriata, the current head of Psychiatry, University of Ghana Medical School. We have Dr. Erica Dixon, the immediate past president of Ghana Psychology Association. We have Mr. Peter Yaro, who is the executive director of Basic Needs Ghana. We have Paul Abidjanfi of SDA Hospital, Dominus Evinyades. Let's quickly now move to the second round. And please, I'll appeal with you, panelists. So this time, let's be very snappy, just 2 minutes. I think you've had a lot of submission, just 2 minutes, and then we are done with that. So, yes, Professor Sabo, your hand is up. Maybe you may want to make a point before we move on. So please, Prof. Professor Sabo.
Muted.
I think, okay, you are muted, please. Professor Sabo, you are muted. You are still muted. You are talking.
No, somebody muted me there. I've been trying to unmute myself.
Oh, okay, sorry about that. Sorry about that. Okay. Yes, you have a point. Okay, just to unmute you.
I wanted to make a quick point.
Okay.
All right. One honorable, we published data on families' reactions, surviving families' reactions,
right,
to suicide, and so honorable's reaction should be understood within the remit of that experience. Suicide is a painful loss to the family, and is a reason why the pursuit of decriminalization must be done with empathic understanding to our context. The families that we spoke to highly object to that, and we have indicated in one of our papers what we call social injury. And that's exactly what the Honorable was expressing, that to the family, it is a loss to their face, it is selfish action because the person didn't think about how they will feel. It is a disaster of the social image of the family. And that kind of emotions which are provoked by this decision stay with them for a very long time. And so this is just for all of us as we push the discourse. Let us push it empathically, that we have a particular group that are key stakeholders, and these are families of surviving families who have lost their wards to this unfortunate incident, so that together with them, instead of they getting an impression that we are pushing an agenda that doesn't seem to be considering how they are feeling, we do it together with them, just as the Honorable is here, that we are doing this in an attempt to make sure that we don't get more cases. And Honorable, just to quickly help you also, the fact that we are seeking to decriminalize this doesn't mean that even when they are jailed, when they are jailed or punished, they will still not do that. In fact, they still do it in the prisons. We have data showing that in the prisons, they still complete it. So whether at home or in the prisons, they aren't safe. But I just want to flag this, that let us, those of you who are writing in there, we beg you, let us pursue this thing with the highest empathic attitude that we can. We're trying to solve a problem. Thank you.
Great, thank you very much. So let's now move to the last round, which will be a very quick one. So Dr. Kankam, let me come to you. So having heard all these submissions, do you have any advice to us in Ghana how to go about this agenda of decriminalization? Dr. Kankam, you are muted. You are still muted, so we are not hearing.
So I think somebody has muted us. That's exactly what is happening to me. So
okay.
whoever is controlling should unmute.
Or you can.
Thank you. I'm here.
Dr. Kakam, now go on. Yeah, Dr. Sabu, you've rectified that. So you've muted everybody. So now.
Okay. So, Honorable, you know, whatever I was going to say, it's you I want to address. Because I was listening to you, not just as a psychiatrist, as a mother. Because like I said, I've been in practice for 30 years. I've heard from thousands of people, and it never stops gut-wrenching, you know, effects. And as you were talking, I could understand you standing in your shoes, that if how you heard it from Favor was that she chose to do this and next time I'll do this, believe me, just like your daughter, she's saying that with the eyes, with the glasses off of where she was at the time she did that. Hopelessness. These situations are not permanent. And when people get from there, they can be in that same, they can see with that same. So I have heard this from many, many family members and from those who didn't complete, thankfully. They themselves feel guilty afterwards. Why did you do that? These are some people, psychiatrists, among the highest in the suicide rate. We are humans too. So it has nothing, it has to do with when you are in that state, you cannot see what you used to see. That window is close to you. The will to live, we take it for granted. That window, bad things happen, and we open the window in our mind and see hope. When that window is shut, we can't. I always tell family members and people that won't is different from cannot. Okay. So I understand you, and if studies show that putting people in jail will save them, I think we will do that. But that's not so. And let's go to the origin of the law, because I researched it at some point. It had nothing to do with illness. It had to do with the European people in the 20th century, where the kings believed that the citizens were their property. So if you do anything to harm your body, you are destroying government property. Nothing to do with illness. That's what stayed in. And they did away with it once science showed that there's a group that may destroy themselves based on illness. Now, the other thing I want to address is that when you say your daughter was happy and didn't seem anything wrong, come to my waiting room. When I first brought my son as a child to come and help me in my office, he said, "Mommy, bring some of my friends here. The people sitting here, they are like uncles and aunties. But those people sitting there, when they come, they have our thoughts. Nobody can, I'm sitting here, my lipstick on it, but you don't know what's going on in my head.
Yeah.
You don't know what happened." And so just the fact that one is smiling doesn't mean that I'm fine. It's in the thoughts. You know, Dr. Dodoy went through the affect. It is not the tears that kill. It was put there to relieve. It is the thoughts that you cannot see hope. So I hear you as a parent, and it's the awareness that is important. I want to address the influencers, because at the time, even though I'm not in Ghana, thanks to technology, I'm on, advocacy platform, and I wrote an open letter, thanks to Dr. Professor Say, who facilitated. I wrote an open letter to the Honorable Idrisu, and Professor Frimpong Boatin is my classmate. And I also wrote to him and I said, go and talk to your friend. You know what? education is so important. Everybody is human. Everybody, the parliamentarians don't want to lose people. He, through Favor talking to him and through from Boateng, who took a picture with him and he gave the okay to send it to me and to others, understood. Okay, so we need to find a way. Sometimes we, the healers ourselves, don't have the language to talk to the common. We know our book language, but we don't have the language to talk and explain things. So yes, if there's one thing, it is explaining awareness that these illnesses, it's like pain. You can't see anybody's physical pain. By the time they go in, ouch, ouch, the pain was already there. So what is common among, whether it's illness, social determinants, is despair and helplessness. And if you have seen, if we saw the pictures of 9/11 people jumping off 54 floors, they were running away from the fire. Something else killed them. So, I'm just, you have touched my heart, and believe me, we are doing everything we can to save people like your daughter and others. Thank you.
Thank you very much. Look, so now we will need to do a lot of public education. That has come up very, very strongly. So if we don't get the public to understand and all segments of the society to understand, maybe we, the mental health workers, we should also take part of the blame. We need to step up the game. Now, Professor Osafo, to what extent do you think further studies will help in the fight against suicidal behavior in general and in the decriminalization agenda in particular?
I think two or 3 points quickly. First is that we need data to show those who are vulnerable, which all of us are at risk, but some persons are vulnerable than others based on their current circumstances. For example, we're finding out in our data that our students who are having problems in studying and academic underachievement are vulnerable. So we need data that will show us those who are vulnerable and what can be done. Data helps you to plan intervention schemes. For the past 8 years, one of the things that we have done is that we have translated our data into gatekeeper training. That's one of the things that we have done in Ghana, so unique compared to our sister countries in the sub-region. So we get a data, we train police, we have trained, for example, school counselors. We get data, we have trained queen mothers, we have trained police officers, we have trained the media, we have trained religious leaders. So data is needed to push the educational agenda, just as you rightly mentioned. Educating persons or people on suicide doesn't occur in a vacuum. We need hard data to show them why we are saying that this is so bad and must be changed. The second thing that we need data for is that data will show us other areas that we need to address. For example, an area that we need quickly to address is to look at the intersection between violence and suicidal behavior. And I'm talking about violence at home. And so for those of you who are into research on this issue, that's an area that we need badly to look at. And we need to work closely with DOFSU to study the incidents of abuse and all kinds of domestic violence and how this translates into, affecting the psychological integrity of persons who are going through crisis. Then the third thing is that we need data to speak to our policymakers, the parliamentarians, the judiciary. I remember through Mental Health Authority, we did this training for the judges, where we have not succeeded completely in expunging this particular law and provision in our criminal code. But at least to a certain great extent, we have succeeded in keeping the law in limbo. And that is not to say that that's the best approach, but at least I believe that a lot of judges are cautious a little bit more these days to jump and say, let me prosecute somebody when the prosecutor brings the case. And so we need data to articulate to parliamentarians and to judges and all the security apparatuses, including for example, the police officers, that if you came across somebody who was in distress, your first thing you do is not quickly to just prepare a docket on the person and take the person to court. But your first is, as provided in the law, you will create and follow through the diversionary processes and send the person to places where the person need help. And finally, we need data on suicide in Ghana to guide all of us in the public suicide literacy that we are all talking about. Many people think that this is just something that is a diabolical intervention. There's an evil, there's a satanic issue in the equation. Well, I am a man of faith, much as I will not dispute people who may think that there is a demonic dimension to this. What is most important is the point that suicide is multifaceted. If it is even demonic, work together with others who are in the psychocentric, profession, and let them unpack the demonic, the mundane, the medical, because we are working together. So on that note, this is what I will say to all of us.
Thank you very much, Prof. We certainly need data, and I think going forward, we need to embark on that. We need to support your department and the other researchers so that you can come out with basic data which we'll use to convince or to push our advocacy agenda. Now, Dr. Dodoe, so far you've not brought in, all of us, we have not brought in COVID issue. Now, in the light of COVID-19 pandemic, are we likely to have a case of suicide or suicidal behavior impacted on negatively by virtue of suicide, COVID-19? And if so, how do we reduce or avoid this chance? And be very snappy for us, please.
Okay. I find it interesting what Prof. Osafo is talking about. And you see, we need data and research, but strictly no ethical committee should give us clearance to do research and data on something which is criminal. So our policymakers should appreciate the fact that without repealing the criminality of suicidal behavior, we cannot even look into the causes at all, because we are going to look into the causes of a crime. We are going to collect data and we are going to confess to a crime. So the COVID itself, COVID-19 has been shown to be associated with distress, with anxiety, with the fear of the contagion that people feel. I've had at least 3 patients, all female, come to me that they went to the market and they feel probably they may have had the COVID-19. So that fear is there. Then we've had one who was obviously mentally ill, but he bent his full perineum because he believed that heating or boiling can cure COVID-19. So he went to sit in hot water because of the COVID-19. So we have evidence that COVID-19 is actually worsening the mental health of people. It's giving people depression. It's giving people, especially health workers, an insomnia. With the uncertainty and the isolation, and especially if you're living in a high COVID-19 prevalence area. And let's not forget, this has all come with economic difficulties. So people have, people's income have dropped. And I mentioned earlier that low income is a risk factor. So there's a stress-related conditions like mood and substance use disorder. And these 2 conditions, mood disorders, especially in depression, has highly linked to, to suicidal behavior. So let me just look at what has happened in the past. Let's look at what has happened in the past. In the Spanish flu, 1918, there's evidence that, it was associated with increased suicide rates. And this was believed to be due to increase in social integration, decrease in social integration, and an interaction between, during the epidemic and the fears caused by the epidemic. When we come to SARS, it was also observed that there was significant increase in suicide rates for a person more than or equal to 65 years old. And this was attributed to fears of contracting the illness. Again, that fear is there. Fears of being a burden to the family, general anxiety, social isolation, and psychological stress. We look at what China has put out now. They say that they did a survey up to about 53.8% rated the psychological impact of the outbreak as moderate or severe. 16.5% reported themselves to have depressive symptoms. When we look at other studies, even in the US, 45% of adults in the US report that their mental health has been negatively impacted due to worry and stress over the coronavirus. So there have been many studies that have shown us that, in fact, with the pandemic of 19, there are many more people who are experiencing stress. So this means that for people who are predisposed, people who already had a mental illness, it's going to be worse. This is coupled with the fact that people are afraid of coming into the hospital for fear of contracting. So even people who have been diagnosed and are on treatment are likely to also not comply with the treatment for fear of getting. So the chances of we getting suicidal behavior is actually going to increase during and get worse after the pandemic. So in fact, with the new normal, we should expect more suicidal behavior. And if we do not have this law repealed, we do not have in place, somebody asked in the chat column, what is the outline for somebody who is suicidal? What should we do? There should be a clear guidelines to all healthcare workers what to do. We should aim to reduce stress, anxiety, fears, and loneliness in the general population. So for the first approach, the public health approach, let's use social.
I think the network is not helping. Network break. Okay, whilst you are trying to resolve your network, probably you can look at Dr. Collins, Dr. Badiadman. You may take your point now. So as the president of the Professional Association of Psychologists in Ghana, what do you think is going to be our next move or your next move in this agenda of getting the criminal code, that component of the criminal code repealed? I think you're muted. You've all been unmuted, so you can unmute from your end.
Okay.
Yeah, that's right. Thank you.
I think I'm on now. So first of all, I want to say I'm very excited with the posture of my own father and my MP from my area. And I like the defense that you have put for your friend, Honorable Joseph Joe Wise, as we call him. What Joe Wise didn't know is that my father comes from Kensri in Bekwai. And I called my family members for them to search Joe Wise's house, that I want to start my petition from there. And so I am very happy with the accommodative nature with which our Honorable MP have highlighted. I am clear on my mind that some of our MPs need patient education. We want them to give us time so that we can educate them. So on the basis of that, my first proposition in the steps towards decriminalization is to request Professor Kwesi Osei, immediately after this meeting, put a panel together. It could be who we are here and many others. Put a committee together so that we book appointments with the Select Committee on Health, Parliament Select Committee on Health, and then we meet them. You'll be excited to meet Joe Wise and Haruna Idrusu themselves, so that we can educate them further. So that is my first proposition. Now, I am confident in my heart. We don't want to give timelines, but next year's Suicide Prevention Day shouldn't happen when we have not repealed this particular act from our laws. That is the kind of conviction I have. My heart goes to the many people who have gone through this particular situation. The last time myself and other colleagues handled suicide-related cases, just 2 days ago. And every day, they keep coming. So my heart goes to all family members who live with such ones, who go through these challenges. And that is why when I read the comments by Honorable Anyumeduenchi those days, my heart went out to you, and I still feel the same way. But one thing I need to say, decriminalizing suicide is not in itself enough. Please put on record. Decriminalizing suicide is in itself not enough.
Sure.
Professor Osafo just mentioned we need data. Professor Osafo, you know, I am always straightforward. We need data. How do we get the data? We need funding to be able to get that data. Apart from decriminalizing, we also need funding. We need budgetary allocation. I wouldn't ever want to sound political, but I will be constructive to ask how much budgetary allocation is going to feed mental health related projects, mental health related initiatives. This is a question I want to hang around the neck of Honorable Anyumeduenchi to help us address this matter. Perhaps Honorable will be thinking, what do you mean by mental health initiative, mental health projects? I want to help you. Now, in your constituency, can you tell me any psychologist practicing in your constituency? Can Honorable tell me, I know you have a number of secondary schools in your jurisdiction.
No, there isn't.
Are there
I'm not sure there is any.
You are not sure there is any. And
yeah,
what you just said, people may appear jovial, and I'm quoting the words you used times ago. People may be lovely, very jovial, but may be going through a lot of tough, challenging situations. We do not have psychologists deployed all over Ghana. Can we have at least one district, 2 psychologists? Why don't we consider this? Especially given the data we have shared so far. So decriminalizing is not enough. We need to deepen the access to mental health care. We need to deepen the opportunities people will have to be given the support. For instance, why don't we introduce mental health studies at the secondary school level? Now, given the challenges of coronavirus, as my Akonta Dodoe mentioned, we are talking about using technology, using the tablet, using internet. Have we quantified the mental health implications of students, young students, as young as 3 years, beginning to use internet, as young as 5 years, beginning to surf the internet? Have we quantified the mental health implications? So my submission is, going forward, as we decriminalize, we should begin from today to think of introducing mental health studies so that we introduce students to the need to speak to a mental health professional, not when you are not well, but even when things are well, so that we can actually carve a niche for our future drive and continue to follow. Next, my submission that I want to make is that indeed we have a lot of counseling and career support units in the universities, if for nothing at all. KNUST, they have a unit. University of Ghana, they have a unit. I know Dr. Nayet from Winneba, they are here, they have a unit. Cape Coast, they have a unit. UPSA, they have a unit. Before we begin to expand the human resource capacity of mental health care, can we take the initiative together with the Mental Health Authority to resource these units? They are already existent. Can we resource these units adequately so that they can expand their capacity, just as we did for COVID-19? We expanded the capacity of hospitals, smaller ones, bigger ones, so they can also do the testing and sample taking. Can we also increase the capacity of these already existing mental health support units, in addition to ensuring that one district, 2 psychologists in the next 2 years? Can we increase the capacity so that indeed we can continue to help the immediate society, immediate catchment area? That is another thought that I want to put in. And lastly, the media needs education on how they report on suicide-related issues. For instance, if the media is educated adequately, and then National Media Commission work with Mental Health Authority and Ghana Psychological Association, we will not see any report on suicide with the noose or the rope hanging there. We will not see any report on suicide with murder written in red around a pool of colored what? Colored red what? Colors. We will not see descriptions of exactly what may have happened in our media reportage. We will not see images indicating how people are lying down, presuming that these people died from suicide. These and many more are some of the things I think going forward. By next year, we will have this law decriminalized. I have the confidence. But we need to begin to put all these things in perspective.
Thank you very much. You've given us a lot of hope. By next year, we will be talking about working towards decriminalizing, but maybe sustaining or making gains out of having decriminalized. That's what I'm thinking about. Now, Favor, you have told us what you went through as a survivor, and I'm sure you probably have a network of other survivors. Is there any way that you can mobilize them in an attempt to push for this agenda of decriminalizing?
Yeah, thank you, Doc and Prof. Sorry. We have several support groups that are working towards helping others who are going through similar situations, and then also supporting ourselves so that we don't get back, or we don't fall off from where we are now. What I would say is that because of the stigma, it is quite difficult to get people to come out to say that I attempted or I have been through, this phase. But we have a few people like myself who are ready, to champion this cause till we get this whole situation turned around. And I'm so happy that, our target, we have put timelines to it. So I would also work with the various groups that I am in and talk to those who are ready to join. And to my daddy honorable, I want to say that you have another daughter, and I'm going to come till you tell me not to come again. So today you had another daughter. Definitely I can't replace my sister, but I know that I would make you as happy as she made you. So be ready for me though, because I'm going to trouble you until we decriminalize suicide in Ghana. So for my colleagues who are on board, Dr. Also, you already know that we have the mental health advocacy platform and then other groups. So we'll put all of them together, and then our parliamentarians should be ready to accept us when we come knocking at their doors, because the target is next year. For me, I hope it is done by next month. because that would be my second birthday. I don't want someone to go through what I went through because it is traumatizing. That was my first time ever at a police station. And I don't want, it to happen to another person, because if I had the help that I needed, I don't think I would have gotten to that point. And today, if you chase me with death, I think I will run probably more than all of you, because I am now, able to work and overcome the stresses that I face in life because of the help I got from the professionals. Thank you very much for this opportunity. And we are ready.
Thank you very much, Favor.
Those of us who are
great. Thank you very much, Favor. It's wonderful.
Shall
we get Honorable your final submission here? And so you have heard all the stakeholders and what we are saying about this. So what do you think as your take-home message? What is going to be the role of the parliamentarians? How are you going to be able to mobilize them? And what is your own advice of how we should go about this? We should getting the parliamentarians to be on board.
Honorable is muted.
Oh.
Honorable, you are muted.
Yes.
Okay, right.
Yeah, that's right.
Thank you, Doctor, and thank you all. Like I said earlier, I am highly educated this afternoon from morning till now. I'm highly educated. This is something that I wish never happens to anybody or any family for that matter. And what we can do is to help prevent this. In as much as I
Oh dear.
Sorry, the network is not helping.
Yeah, Honorable's network.
need to
Yeah, the network
educate.
is not helping.
Can you hear me, Doc? Yeah.
Yes.
Yes, I can hear you now.
Yes. In as much as I agree that other things, institutions and whatnot be put in place. I think that education must be key. I read a TED speech, much interested in that. I support him. For instance, 3 days ago, she was feeling that people were chasing her. I caught her, and you could see that she was shivering. She was in fear. She said, "They are coming after me. They will kill me." Then the mother followed. I put her in my car. Let's go to hospital. In Konongo, as was asked, it's only a mental health nurse we have. So I called the doctor in charge. Then the mother said, let's send him to Osofu. I sent her to Osofu. And I sent the girl to Osofu. Osofu gave some concoction for this girl to drink. In 2 minutes, she vomited and she was all right. But I think Dr. Say would say that the mental problem is still there. Unfortunately, I'm in Accra today. I need to follow up and then give her the necessary counseling. So we need to educate the public. We need, including parliamentarians. But I can assure you, Doc, that once we are able to lay the basis, this is a law, a criminal act. It's part of our criminal act. It is not an ally. So we need a substantive law. So like I said, Law Reform Commission, if we push the Law Reform Commission, they will bring it to Parliament. Then we have to involve the Constitutional, Legal and Parliamentary Affairs Committee, of which I'm a member. And then we can also liaise with the Health Committee. And I am sure this would be solved in no time. Parliament will be resuming on the 6th of October. And I will follow up with you, Dr. Kosiose, so that together we may see Law Reform Commission, and then they may draw up the bill that would seek to amend this, and we would get it over us. I'm totally in support of the fact that we have to decriminalize this. And my newfound daughter, tell her that when she comes, I will beat her before I talk to her. Thank you.
I'm ready for the case.
I'll give you some
Thank you very much.
Right now.
Honorable, I have the feeling that you meant you would have beaten her those days, but now that they come to understand this,
Yes, I know. I know.
So thank you very much. Now,
right.
I think we can open it to one or two or three questions or comments, and a lot has come out from the chat, and you've been answering them, or some people have been answering all along. But if there is any one or two burning issue that anybody wants to bring up by way of question contribution, please feel free. That's the floor. They're not all the participants. And whilst waiting for that, let me acknowledge the presence of Dr. Pina Manapao, the director of Accra Psychiatric Hospital. And we also had Professor Patrick Gagan. We had Faustina Nyako, the regional mental coordinator at Ashanti region. We have Humphrey Kofi, executive director, executive secretary of Mental Society of Ghana. And of course, you all others. Forgive me for not mentioning you one by one. So now I open it to comments, questions, open forum, just a few minutes. Yes, sure. Joy. Great. Please go ahead.
Thank you very much, all the resource persons, for the hope that you have given us in suicide prevention. We are very grateful to you. We've learned a lot, and we hope that as the timelines have been given, in a year's time, we'll be looking at the way forward after decriminalization. It's been very insightful, and I'm as part of the program. Thank you so much.
Thank you very much, Joy. Now, Sarah Mata, please, you have the floor. Unmute and then, yes.
Right. Thank you very much, Doc. I'm happy to be part of this. As we are trying to help to take the law out to make it not criminal again, I also want to encourage members and colleagues that we need to education and sensitization around. I was lucky to be part of the COVID-19 team at my municipal Asante Mampong. And when the students were in, so two of the students nearly committed suicide. I had to be called to go in and talk to them several times before things were done well, and they are now okay, happily. All of them are now recovered and they have gone home. So I think we need to do the education to both teachers. I'm concerned about teachers and educationists. To both teachers and education in our schools. And even our training, my research was on knowledge of counselors in schools on depression. And we found that most of the training that we give to the counseling psychologists and those managing our institutions don't have much knowledge about mental health or how to even deal with depression. So our training also needs to be changed. Then this will help us to reduce the stigma, to reduce the issue of mental health in our schools and our society, because it's starting from my studies show that even as young as 3-4 years, also tempted, young ones are doing it, adolescents are also doing it. So we need to encourage and increase the awareness creation that suicide is part, it's not a criminal issue. We only need to talk to them, and I believe we'll be able to reduce this menace on us as a nation. Thank you all for the opportunity, and I've enjoyed the program. I thank my president and everybody and all my lecturers on the platform. Thank you very much.
Thank you very much. Do you have Obin, please? Obin, you can take the floor. Yes, Obin.
Thank you very much, Doctor. I'm grateful. I indicated earlier on the page. I think that what we also have to do, I'm a media practitioner. I'm managing a radio station and a TV station in the central region. And I'm thinking that what we can also do to enhance the campaign is to develop a communication strategy so that together we can all have a common voice in pushing the campaign on the radio and the TV and the newsprint platforms. Whilst the medical experts to work on their side and the legislators also work on their side. We, the media guys, too, would need a communication strategy to be able to.
Good. Okay, thank you very much. Ms. Obin, you are hitting the point that we need to bring the media on board. So that's very important. Christina Osiansa, please, you have the floor. Christina? While waiting for Chrissy, can we have Kezia Arthur? Kezia? You may unmute and talk, please. You are muted. Okay, then Matthias, Chair Abiu, can you unmute and then make your point, please?
Okay. Thank you very much, Doctor. I am a mental health nurse in the community. And then we are the first point of call when people attempt suicide, when they are brought to the facilities. And it is so disheartening that since I started practicing for over 5 years now, we've not had any specialist visit to our setting in the community. So whatever we do is to get the patient, tell us their problem. Then based on what they said, we try to give some sort of counseling and then help. But I'm sure if there were specialist visits to our places of work and then further training, we can equally be sources of help to people who have attempted suicide. Thank you.
Thank you very much. Chrissy, are you now, can you unmute and make your point?
Okay. Good morning. Please, I'm Christiana from Accra Psychiatric Hospital.
Okay.
I'm encouraging nurses to make use of our churches and also our OPDs. Make the language of suicide more convincing for them to understand it more than we using our technical terms to explain it to them. And I think with that, they will also help us in selling out what we want to communicate to the people.
Thank you very much. Point very well made. Okay. On that note, let me just, I'm not attempting to summarize. I think a lot of education has gone on, a lot of information has been shared. So just pinpointing a few key messages as take-home messages. We've agreed that it is already suicide behavior, and that includes attempts, contemplation, and completion. Suicide behavior is already a public health issue. It's not now becoming, it's already a public health issue. We've known that more people die from even the COVID so far. So we need to recognize that. We also have agreed, we've been told that there is an ABCD of suicide, the affect and all those things, and that's a take-home message with the suicide equation. We have understood we need to embark on a lot of public education. If you don't educate the public to understand, many people don't even recognize there is a law against suicide or suicide attempt, which we need to work to repeal. People don't understand what goes on in the minds of people who attempt suicide. We have also understood that let's not say commit suicide. Let's take one's life through suicide or death through suicide. It's because committing reinforces the criminality of it. Yeah. So that's something we've also learned. We've also appreciated that we need to get the media on board. We need to also get to understand the mindset of people who think it should remain a criminal offense. You need to understand their mindset. And with that understanding, they can work on that. But that's very important. We have recognized that the COVID pandemic definitely is going to increase situation. In fact, this is what I call post-COVID traumatic stress disorder. It's not yet a term, but the principle is there. After the COVID, it's like post-traumatic stress disorder. We are going to have, if you like, an explosion of mental health issues, including suicidal behavior. So we need to prepare for that. Data is crucial and research, very important. Attempted suicide is not a crime. It's a call for help, and therefore we need to decriminalize it. We have been given hope that in a year's time, latest, you will certainly get through. The MPs have assured us, or we've had the assurance from the Honorable Member of Parliament, that the MPs are there to support us. Let's give them the education and let's take the steps. Along that line, what we've also realized lately with the Mental Health Board, we realized that we will need to send a memo from us to the Ministry of Health, and showing why it should be decriminalized, and the Ministry of Health will then write a memo to the Attorney General showing the path of the law that should be repealed, and then the Attorney General will prepare memo or statement to Parliament. And when it gets there, the parliamentarians will support us. I think that stuff is very, very important. I mean, once we are through with this, we need to get there and make sure that truly we can get the issues of the challenges of suicidal behavior being decriminalized. That's very important. We have had this program in collaboration, that's the Mental Health Authority in collaboration with Ghana Psychology Association. And we are very grateful that we had it. I must apologize for the challenge. I thought our platform would allow a lot of people, but we realized that it only takes up to 100. So after 100, many people were in the waiting room but could not join. It's only when somebody's network dropped that the person was able to join. But at least we had 100 people at any time listening, and we are very grateful. I want to thank the panelists, Dr. Kankam. At the time that you came in, it was late. I'm sure that probably your sleep was not yet through, but you managed to sacrifice and join us. Dr. Ajuman, we are happy you made the time to come. Professor Safo, I know how your research is going, and therefore we are really very busy. We thank you for coming. Dr. Dodoi, all the way from Ho, even though not physically on foot, I mean physically, but to join us, we are happy with that. Favor, we are happy you will continue to push and make sure that we all get through that. And then Honorable Anyimadu Entry. And I must say, Honorable Anyimadu came not just because of my personal relationship. He's like a brother to me. But that's a different, but from the submission, he has that personal touch. And it was important to get him on board to share, and then through him to get the parliamentarians. And then you all participants, we are happy you came, a lot of you, and you take all your issues on board. Dr. Professor Safo, I think you have your hand up. Maybe you may want to give maybe one point that Professor Safo, as you are coming on board, Dr. Dixon, that yes, we know there are social issues that push people into mental health. Is it possible that they all culminate, at least most of them, through a final common pathway of a mental health issue, either predisposing mental health or at the point of the attempt, there may have been some acute stress disorder, which is a mental health issue. Can we make that connection that from social issues pushing people through the mental health spectrum, and at that point it becomes the immediate cause of attempt? Would you want to address that? You are muted, Prof. You are so muted.
I think, Prof, you may have to unmute.
Yeah, you're on now.
Yes. Okay. Yeah. So a quick one. I wanted to request that when we are done with this, maybe the presenters we should still remain for discussion that I want to.
Good point. Sure. Good point. So please, panelists, stay behind and let's have a little a few chats, a few minutes.
And then they have.
All right.
The last point. Prof, should I go on?
Yes. Yes.
Okay.
Please go ahead.
So the last point I wanted to make that is to all of us on this, that let us be very cautious pushing a mono approach. This approach is currently under serious review because it has made the fight against suicide difficult. And a mono approach simply means that suicide is physiological, suicide is psychological, suicide is medical. This has been a very, very serious issue in recent times. And that is why if you see IAS has still left this theme working together on to run, because current data is showing that this silo thinking and particular way of looking at suicide, that it is purely psychological, it is purely psychiatric, it's purely sociological, doesn't help. But what is coming up rather is that we should look at the person, number one, and the context of the person. So what is happening to the person and what is happening in its context. And so for all of us who are here, please don't only look at what may have happened. Yes, the person might be depressed, but Dr. Doi warned us on that. We have seen that there are a class of antidepressants that rather will push the person to be suicidal. Look at what is happening also around the person. So working together opens us up to the possibilities of looking at all other factors that may, for example, predispose and the need to work together. The other details, when the presenters meet, we'll discuss this. Thank you, Prof, for the attention.
Point well noted. It should be a coordinated program and not just a silo approach. That is well noted. On that note, I want to thank you very much. In fact, I must also add that there is a webinar record of this, which will be on YouTube and other social media platforms. So you can go back to review, or you can invite others to join and to listen to that. So that those who miss this opportunity will still be able to get the feel of what happened. Thank you very much once again, and I'm happy and I appreciate your coming. And this proves that we can have more of such webinars on related topics so that we can take the campaign forward further. Thank you very much and enjoy the rest of the day. Bye-bye. But the presenters, please remain behind so that we can have a little chat.